Please welcome President and CEO of Intermountain Healthcare, Marc Harrison, and President and Chief Executive Officer of Cambia Health Solutions, Marc Ganz, who will be interviewed by Managing Director, Senior Research Analyst for Leerink Partners, Anna Gupte.
So thanks all, good morning, and we're looking forward to a very good session on throwing down the gauntlet with what I think are two very visionary leaders who have embraced change, embraced transformation, and come from two very different sides of the healthcare spectrum. So we have Marc Ganz from Cambia Health Solutions, which is the parent company, for those of you who don't know, of Regence, Blue Cross Blue Shield, but they also have a venture arm, an innovation hub, and so on. And we have Marc Harrison, who's the CEO of Intermountain Healthcare, and he comes from a provider background from Cleveland Clinic, a lot of international experience from Dubai, and has also been a very transformative leader. I think both of them are quite excited to be on stage together, and I believe it's the first time. So I'm going to start with you, Marc Ganz, and if you could talk about transforming healthcare is hard with all the vested interests, entrenched competition, a very regulated environment. We've been hearing about this for the last couple of days, increased government pay, but also more demanding employer payers as well. So what exactly do you feel has worked for you so far? And I know there's a lot more that needs to be done organizationally, if you will, to achieve that change.
So we start, I guess one of the things is change, transformative change takes a long time. It's sort of that notion of you have to put in your 10,000 hours before you can overnight success, that axiom. I think that's very true. We started down our path in 2004. And our view was that the problem was not that we needed to improve things within the current structure of healthcare. We looked at it and said, the problem with healthcare in this country, the elephant in the room, is that the economic model itself actually delivers exactly what it was designed to deliver, but it causes good people to make logical business decisions that lead to suboptimal results for the people we are here to serve. So we took that on and said, that has to change. And we, if not us, who, and if not now, when, we're not gonna wait for the government to do it or someone else in the marketplace to do it. We need to take that risk. Mm-hmm. And so our board took a leap of faith, I think, with us back in 2004, and we began the work. What I would say is it was important to have clarity of the vision and constancy to that. The vision we set forth in 2004 is exactly the same vision that we have today. The core strategies are basically the same because it's a long-term play. And then the most important thing was working on the internal culture of the company and trying to tune the culture around us to be able to be ready for a transformative change.
What about you, Marc, at Intermountain? Organizationally, both to overcome impediments internally and externally, if you will.
I think transformation is really easy. I don't know. Right. Look, this is really hard stuff, and I really appreciate Marc's comments. From our standpoint, I'm very lucky to inherit an organization. I've been in place at Intermountain for about 18 months as CEO now. We're already oriented towards population health and value to a large extent, and that is a real gift in this environment. And then the question is, how do you operationalize that, and how do you really get some momentum? Probably the biggest thing that we've done to drive on that front is we've recognized that we're fundamentally in two different businesses on the clinical delivery side of things. We're in the keep people well business, and then we're in the take care of people when they're sick business. And creating a healthy tension between those two parts of the organization are key, and actually carving away all the functions that actually keep people well and turning it into a standalone enterprise or largely standalone enterprise is what the process of we're doing right now. When we get this right, and I absolutely believe that we will, the very good integrated delivery system that we have that is effective at population health and creating value is going to go through a step change. And that's what people need. Healthcare is too expensive, the quality is not good enough, it's too inconsistent, and it's dehumanizing in a lot of ways. Once we make this change, I think we can really deliver that next generation of keeping people well. Mm-hmm.
So as you think about the two profit pools, and I understand the vision is to transform and look at the pain points for the consumer and so on, but there is an imperative to manage your capacity from a hospital health system side of the house, and then there's the underwriting, profits on the health plan side, and how do you optimize the two, and does one take precedence over the other, and how does this then align, if you will, with the consumer, which is where both of you have wanted to go, and how does this solve something for the American consumer?
Well, I reorganized the company and brought all the voices to the same table. And there's only one P&L that counts, it's for the whole organization, and there's only one delivery of value that counts, and that's to the communities. And I will tolerate no conflict that actually detracts from either of those things. And so if you can't play as a team, then you're not going to be on my team. So we're actually doing pretty well. Yeah.
Okay.
It's got to be crystal clear. There are many integrated delivery systems that are actually incredibly fractured and fractious internally. And who suffers? It's actually the people we're meant to serve, and that's not okay.
Mm-hmm. Now, Marc, healthcare is delivered at the local market level. I would say that you have the benefit, right, as the Blue Cross Blue Shield of more market concentration than maybe some of the larger national players that are fairly dispersed. So nonetheless, it's challenging. And can you talk about how you brought together the various entities, let's say in the Pacific Northwest, in a particular market, employers, health systems, physicians, and then your own organization toward maybe one tangible or two success that you can share with us?
So I think that collaboration has been very difficult in healthcare, much more difficult than it should be. So again, it starts with having clarity about where you're going and being candid within the company. I think it's interesting what you said in terms of how you brought people together around common table and said, you're a single team, work together as such, and I like that. I love conflict in my team, but not negative conflict, but conflict because they are fighting to figure out how to do something together that really, really matters. Mm-hmm. And when you're trying to transform a healthcare system that really is resistant to that, you have to be open to, as a leader, to bringing in as much diversity of thought and ideas. And so to me, it starts with the way that you kind of run the company and the cultural norms you set. I would say the company, when I took it over in 2003, was a very traditional, rules-bound, top-down organization, and it worked in a certain way, but it was all about perpetuating the present. And so we had to bring in a lot of new people from outside the industry from industries that had something to teach us. Mm-hmm. And I guess part of my job was to have their back so that they could be disruptive to the all too comfortable and polite environment, and get through that, and so that's how we could change the culture. I think outside the organization, more to your point of your question, is I think it's the same process. It's finding a few fellow travelers, going deep with them, and taking real risk. I find that that has been hard because a lot of people are very wedded to their revenue model, and we're not going to change things we are not going to change the system by clinging to our revenue models and kidding ourselves to say, oh yeah, we can be different, but don't touch that. And so we are in that process. We've been in that process. And with partners, finding partners that are willing to do that as well, hard to do. But I see more and more movement in that direction. And we did something with OHSU in Oregon to be able to serve the ACA market that was really something they had been completely resistant to for years. We went into business together. We have a product that we are completely upside downside risk on. We created the product together. We decided on the price to market together based on their needs and what we wanted to be able to bring to the market. And it's a fledgling experiment, but it's working. It took a lot of faith and a lot of trust. People had to open up to each other in ways that in previous environments, let's say our contracting teams would never have allowed. But we did it strategically and we got somewhere.
So Marc, to follow up on that, sounds like the payer-provider JV-ish kind of model, or maybe a shared partnership with shared economics worked for Cambia. You yourself have a payer and a provider system inside. Can you talk about what this means for your organization, and then more broadly for American healthcare? Where is this going in terms of payer-provider convergence? Do you see this ending up eventually into more integrated, fully integrated models, Kaiser-like, if you will, or will it just more converge around, an ambulatory axis where United Healthcare and more recently CVS, Aetna, and others are, coming up with the more retail, if you will, front door to healthcare?
It's an easy question, right? Look, for us, the payer-provider model is key to our success. About a third of the volume that we do is now fully capitated, and I think you reach a tipping point at about that proportion, where it really colors the way you think about everything. What I think is beautiful about it is we get to do things that don't make economic sense on a case-by-case basis, but make sense for a population. I love the fact that we can give people rides so they make it to their doctor's appointments. I love the fact that we can actually talk about things like food insecurity and housing insecurity and have it make sense economically to the population as a whole. The irony is that I'm an ICU doctor who thinks about nothing but public health right now, and it really works. I actually am extraordinarily optimistic about the future of American healthcare, but I'm not the least bit optimistic about most legacy healthcare systems. They are designed to preserve the status quo. They're designed to preserve the stability for the providers and the executive teams, but not for the patients. It's a very, very selfish model, and they're addicted to fee-for-service revenue, and it's going to be their death knell, I believe. They're going to have to figure this out. In the absence of real risk sharing and real alignment, nothing's going to get better for the patients, members, customers, whatever you want to call them. And in the end, I think those systems are going to really face crises.
Mm-hmm.
And what about you for Cambia? Is this, again, a move to value-based care? Would you say you can say it's about a third capitated, or a portion of it is risk share, and where is value-based care going for you and more broadly?
For me, it's a little simpler than that. Value is in the eye of the actual individual and family. And we must never forget that, and yet we do that all the time. I was with a group of health system executives, so what you said just resonated. And they were having a conversation about, in this case, scale. And they engaged for almost 90 minutes in a conversation, an echo chamber about why getting bigger was such a cool thing. And I sat there and didn't say anything, and finally somebody said, well, Marc, you haven't said anything about this. What do you think? And I said, well, and this meeting was in Phoenix, and I said, You know what I think would have been really interesting is if we had gone out and we had brought in some people off the streets, just regular people, into this room and had them line the walls and listen to this conversation over the last 90 minutes. And I said, do you think that they would think that we were talking about them?
Here.
And the room sort of erupted in this sort of uncomfortableness, and there was a lot of defensiveness. And I said, look, the way I look at it is most of you have already done mergers. You already are the product of that. The very things you said 10 years ago, 15 years to justify how the consumer would win by doing the mergers is what you're saying now to make the case of why you should get even bigger. What have you actually done? And I said, because as a partner, business partner with you, and sometimes, with my family, a customer, I'm not seeing it.
Here.
And so I really think that a lot of times in healthcare, people think that something like scale is a strategy. It's not a strategy. It's a tactic. It can be a good tactic if you are clear on your strategy, and your strategy is about the people you serve. And I think you're right that I think it's true. I see it in health plans as well as in health systems where there are organizations that right now are trying to survive. They're trying to preserve. Bad words. What are you doing to actually, how curious are you about individuals and their families? Do you get out and actually see them? And if you see them, you can't not feel compelled to want to move as quickly as you can to change it for them. And I just think that the good news, because I'm optimistic as well, is for whatever reason, I think we're in a window where it's actually starting to happen. And that's where organizations like us need to collaborate more. We need to check our swords at the door and really look at how do we interact differently, because the unifying factor in all of this is the individual and their family. We all serve that individual.
Anna, you asked about some of these new
retail models, and
Right.
there's a transformation that's happening, right, in the care
totally
delivery
happening.
landscape.
And that's actually, we hope to be the first integrated delivery system that actually makes that transformation internally. That same sort of real asset-light, team-based model, and we're in the process of doing that. Is a lot of what our reorganization is about.
Great.
But I think the trick is, and again, I'm an ICU doctor, and I love clinical medicine, and I just don't think it's that simple. I think people are still going to get hit by cars. They're still going to have heart attacks no matter how, bad things are going to happen. And it's fantastic to be able to identify destinations for people who have very complex episodes to have those cared for, but that's not what a lot of healthcare is really all about. And understanding how they interdigitate with an integrated delivery system to provide people with coordinated and humanistic care when they actually make that switch from being a customer into being a patient. And we all go through those cycles. I think that's where it's going to be tricky for them. I'm not saying that it's anywhere near impossible. In fact, the good thing I think is I know, you know that healthcare is going to be of higher quality and more affordable for Americans going forward. The question is who gets to deliver that. And I think we're going to be one of those folks. You're going to be deep in that. Who are the other players? And I think that dealing with the retailers are going to be part of that, but they're not the answer on their own.
Yeah.
I think there will be great disruptors, and I think well, let me say one thing. If we want to have an affordable healthcare system for individuals and their families, it starts with the price. And it's the price of each and every transaction that people have. My dream, and I don't think it's a pipe dream, is that 60 to 70% of the interactions that people have in healthcare, that the goods and services they buy in health and in sickness, can and should be payable on a pay-as-you-go basis. The reason that isn't in place is because of the way that the third-party payment
Right.
system works and the enormous subsidy that is pumped into the healthcare system by employers and by government. Yeah. And so no wonder the prices spiral upward because there is no direct accountability and engagement. So there will still be people who get hit by cars, people who get cancer, and people who need heart surgery, where there are certain services, drugs that may indeed be justifiably beyond the means of an individual or family to afford. And that's where the community financing model, whatever we want to call it, today we call it health insurance,
Right.
plays a role. And that's a real noble thing, that people come together to help each other in times of need. The problem is that model is now part of the problem because it exists, prices spiral up in an unconscionable way. I think that has to get broken, fundamentally broken down. And so I think retail actually can work. I do think that organizations like yours and ours, if I may say so, are probably, if we get our act together, are in the best position to create and win in that model.
And will there be any optimization, you think, just to follow up on your point around the end-payer by payer mix? I think it was very heartening for me anyway to hear more about social determinants of health at this conference than I've heard before. Actually, innovation and ventures that are geared toward Medicaid members and patients. Would you see the sites of service, for example, being optimized by payer mix? Because there is a price equation and a profit equation there, which you may not be embracing really, but I do see it among publicly traded hospitals and plans.
So let me just start by saying our state and region, we don't have a county hospital system. Intermountain provides hundreds of millions of dollars of charity care every year to hundreds of thousands of people. If we don't take care of our economics, then we can't take care of those people the way we want to. So we've got to really run a good show. And so in no way are we cavalier about economics. We have to be an extraordinarily well-run organization to serve our charitable mission. I do think there's going to be a lot of changes in how we deliver care, where we deliver it. We now have a bunch of school-based clinics. So how do you serve a poor neighborhood? You put a clinic in the local elementary school, and when mom or dad comes after work to pick up their kid, they also can get health care in the same place.
And it's convenient as well.
Totally convenient. And then we're going deep on the community health worker model. So I love the fact that we can take folks with high school educations who then have an opportunity for career advancement and have cultural competency in the community that they're serving, whatever that culture might be. Those are the things that are those are different from preserving the status quo where you get in your car and you drive to your primary care office and you check in the usual way and you have to see a doctor, you're not going to see a mid-level provider. That doctor's probably from a really different background than you are if you're a poor person.
Yeah.
I think turning that stuff on its ear is actually exactly what needs to happen, and that's what we're trying to do.
And it's a win-win.
If it's priced reasonably,
Right.
then it will be transformative. Otherwise, it will just be another vehicle of overcharging Americans.
Yeah.
And I hope that as we make that turn, Mark, that all of us who are in this business are figure out a new business model that actually delivers that value at a price that people can look at and say, that's valuable. I'll pay for that.
Right.
So switching gears now to pharmaceutical cost escalation. The president is expected to give a speech on Friday. There's been a bright shining light on the lack of transparency. Standalone pharmacy benefits managers under a lot of pressure. Mergers are happening, I'm sure in part sparked by the integration of medical and pharmacy. As part of Cambia and the broader Blue Cross Association and a leader at AHIP, do you see this problem being solved if you will, by the existing players? How might you do that? Do you see progress to date? Or will there be an Amazon or, the new coalitions with Berkshire and JP Morgan or HTA that are, going to kind of make a dent in this?
There's no question that the large retail organizations are going to have they're going to have a say in this. I think I'm watching most closely Walmart. I actually think that they're dead serious about making a play, and they're doing it, I think, for the right reasons.
Me too.
I think they look at the people that come into their store, the people they serve every day, and it's a lot. And they say, this system, this healthcare system, is not working for them. And we need, there's an opportunity to serve there. So I think that's there's no question that's going to have an impact. And I welcome it. I think the fact that those companies like them are already starting to move and say they're moving in, I think is creating enough discomfort in the legacy areas of healthcare that I think you're starting to see maybe more of an openness to change.
Like point of sale discounts.
With regard to what the president says on later this week, I'm prepared to be disappointed. His tweets will be far more interesting. But no, I actually think that that pharma, has a very powerful lobby, and they have. But something has to change, because I think that industry has come unlatched from what I would call some basic understanding of the lives of individual Americans and how they are actually their journeys through life. And the consumer always has the last say. And it may take a while, but if you cannot hold back that tide, and even pharma that has a pretty good ground game in Washington, D.C., will not be able to hold back that tide. They cannot continue to do what they're doing. It's wrong. It's got to change.
And what about you, Marc? As you think about specialty pharma, which is projected to be 40% of prescription drug spending by 2020.
Can I ask who invented the term specialty pharma?
Specialty pharma, I know it means different things.
Why do we buy into that? Why do we think it's like buying into healthcare CPI as if that's okay, that it's something different than normal CPI? So
I don't know. I mean, I guess it's turned into kind of the injectable versus oral, situation, but it's very odd. I agree with you. It's a pretty odd nomenclature. But the 1,600-ish odd, I believe you employ clinicians. A lot of them must be specialists. The pharmaceutical industry obviously is a part of the problem, but many would say that the channel is a piece of it, with buy and bill. And so, what are your thoughts around the delivery changes? And perhaps what maybe HHS may or may not do, around Part B and moving certain drugs away and treating formularies more like Part D, which may or may not happen.
So one of the reasons I was really glad to come back to Intermountain after almost 20 years away is that there's a really strong culture of evidence-based medicine and care process models. And I think that we have a long way to go in terms of making sure we use these fancy tests and fancy drugs well. But I got to tell you, as a cancer survivor myself, I am incredibly grateful that there are these new drugs, and they turn diseases that crushed people or killed people into things that are manageable and allow them to live good lives.
It's chronic disease now, it's manageable.
For many cases, it really is. And particularly the new immunotherapies are really non-toxic and extraordinarily well tolerated, and in some cases very effective also. Question then is, how do you pay for it? And what is that financing model? One of the things I hope and expect actually is that what we hear from the president is that the U.S. is no longer going to bear the sole burden for R&D for the world. There is a huge middle class across the world right now, and we can share that to some extent. I am fortunate to know a number of big pharma CEOs, and they know that their life is changing. And I find many of them very open to value-based contracting, et cetera. And I'm hopeful that for all the right reasons, they're going to change along with us to serve better, but still keep that pipeline full. They're going to go through a massive transformation. And in the end, I think it's going to be really good. Healthcare is going to be more affordable. We need to deliver the care in an evidence-based fashion, but there's so much good that can come for the people we serve.
So we're getting to the end of the session. We are at Health, HLTH, the future of healthcare, and we are doing a throw down the gauntlet session. So what I would love to see is maybe from each of you a final thought for the audience. And all of us are part of the healthcare system and share in the economics and the growth, but we're also consumers of healthcare. You know, can you provide either a call to action or a reason for all of us to be optimistic about this future?
So keep Gandhi in mind. Be the change you want to see in the world, and show courage and transform yourself and your role in healthcare as you seek to serve others better.
So I wasn't going to say this, but since you brought up Gandhi, one of my favorite sayings of Gandhi is, if you're really trying to make change, fundamental change that's based in a profound hope and conviction that transformation can happen, he had a saying, it was, first they will ignore you, then they will laugh at you, then they will fight you, and then you win. And so my hope for everyone in this room is that you are on that journey, that you start and you've checked your heart about whether or not you truly have conviction and hope that healthcare can change, not just that you can do well within the system. And secondly, that you will take that harder road and go through that cycle of being ignored, then laughed at, then fought. And that you know that when you see that, not to shrink away from it, but to realize you're actually winning. You're actually on that path. So that would be my thought.
Thank you so much, Marc and Marc, for sharing your vision and thoughts with us.
Thank you, Marc, Marc, and Anna.